Hello, Dr. James Bogash, expert in health and longevity, and been putting this together for a while. The whole Ozempic, Wegovy, semaglutide, I've been following this for over a decade. This isn't a new class of drugs. It started with Byetta, and it's kind of evolved from there. And you follow the media and you think everything's glossy and wonderful and excellent. So I'm going to cover what this class of drug, where it came from, what the problems are, what the potential benefits are, and what to do if you really have to take this class of drugs, and also even more so, like what we're really missing with this drug and what the long-term outcomes mean. So that being said, we're going to kind of go through here as a kind of a PowerPoint presentation, but we're going to start with, in 2005, Byetta injection was approved for type 2 diabetes. It's a GLP-1 receptor agonist, so it acts like our own GLP-1, which is glucagon-like peptide. It's a pretty strong anti-diabetic hormone. It does things like increases insulin production. It slows down its gastric emptying, so your stomach hangs on to things longer. The longer we hang on to things, the slower our food can get absorbed into the system, so it has a tendency to keep things, instead of the spike, we have a tendency to keep things lower. It also decreases another hormone called glucagon. It decreases appetite. It decreases GI motility in general, which is also part of the stomach delaying gastric emptying. Other examples are Victoza, Trulicity, Ozempic, Mounjaro. These are all kind of different flavors of the same type of drugs. Weekly injections, Byetta, which is I'm not even sure if it's still on the market, was a twice-a-day injection. So now most of them have progressed to the weekly, which is far more acceptable for most people. So our own GLP-1 gets broken down in about 2 minutes. This should tell you something. The human body does not do things without a reason. There's a reason it has a short half-life. Incidentally, just slowing down and chewing more, your body will make more GLP-1. That is why we consistently see studies looking at longer or slower eating and more chewing time, lower risk of obesity and diabetes. That all makes sense because you're producing more GLP-1. So don't take any drugs, just chew more, and you're going to have better outcomes. The other class is dipeptidyl-peptidase 4, DPP4. This slows down the enzyme that breaks down our own GLP-1. So normally we'd have a 2-minute half-life or so. This will extend it, because now our body breaks it down slower, so it's allowed to act for longer. Things like Januvia, Onglyza, they're generally oral meds, so more acceptable, but generally not as effective. Where things started to change, Ozempic was approved for diabetes in 2017, so 6 years ago or so. Wegovy for weight loss in 2021, and that's where the whole market decided to go crazy, and where we are at today. Basically, they're the same drug, it's just a higher dose for Wegovy than it is for Ozempic. Here's the reality. It's like where GLP-1 comes from, like how did this all start, where did Byetta come from? Well, it was made from Gila monster spit. So you'd think, oh, well, like the Gila monster spit is otherwise venomous, like how could there be this potentially beneficial thing within spit of the Gila monster spit that's otherwise toxic? The reality is that the Gila monster only eats a couple times per year. So what happens when it's not eating, its GI tract involutes, it shrinks, just like everything else. If we're not using it, it kind of goes away. But it needs something to cause it to rapidly divide and grow when it eats. So this GLP-1 hormone is in Gila monster spit. So when they eat, the GI tract rapidly divides. Well, this is happening a couple times a year. So forcing cells to rapidly divide a couple times a year is probably okay, but doing this on a weekly basis for extended periods of time, clearly not the way Mother Nature intended. So we look at this And one of the things that we said, so GLP-1, they usually go by RA, so receptor agonists, so they act on this receptor. The realities are that it was promoted as protecting the heart. And so even one of the most recent reviews said that its data from cardiovascular outcome trials demonstrated a robust and consistent reduction in atherothrombotic events, particularly in patients with established atherosclerotic heart disease. So it's protecting the heart, especially in those people who have heart disease. Well, it does, but robust in its major atherosclerotic coronary events, relative risk reduction about 4%. Anybody who's followed me knows that relative risk reduction and absolute risk reduction are two different things. It's about a 1 to 3% reduction in heart disease in MACE rates. Like, it pretty much sucks. That's what we're hanging our hat on. And, statins are probably in that same range, and they certainly haven't. Cardiovascular disease is still the number one killer. Always has been, always will be. And the drugs we have do virtually nothing to change that trajectory. So there's no question that weight loss occurs in most, not all, in most people taking these drugs. So what are some of the side effects? Obviously GI related, because you're affecting the GI tract. So nausea, vomiting, diarrhea is not uncommon. And then the flip side is constipation. Mainly because you're slowing down motility. So initially you're kind of pissing everything off, but then in affecting the way we absorb foods, but then slowing down digestion too much can lead to constipation and even gastric paresis, which we've now seen as several lawsuits, because unfortunately for some people it pretty much paralyzed the stomach, and the stomach never jump started again. So it's what the drug's designed to do. It just overdid it in some people. In most of the trials, you'll see that the GI side effects are what kept people from staying on the meds and stopping the meds. So more concerning side effects are things like stomach ulcer, bleeding, pancreatitis, gallbladder problems. In 2009, 2013, the FDA issued safety warnings on pancreatitis. But what are we doing? We're causing these cells to divide more rapidly than Mother Nature intended. There's going to be a consequence of that. And pancreatitis is not a fun not side effect, but not a fun thing to go through. We also see increased beta cell mass, so the pancreas is getting heavier. You do that long enough, and there's potential for things like pancreatic cancer. We've also seen, we don't quite have the full data out, but these drugs haven't been around long enough, especially with the heavy use of Wegovy, which is only a couple years. It's pretty much in its infancy. So thyroid is definitely on the radar screen as well, but I wouldn't be surprised if we start seeing pancreatic and other GI cancers on the warning list. But isn't it good for diabetics and weight loss? But we already talked about the cardiovascular benefits that are really pretty minimal at best. So what do we see? 1 year after stopping, 2/3 of people regained the weight. Like, that's an issue. This isn't, in other words, this isn't fixing shit. It's just maybe causing more, but it's not fixing anything. Otherwise, people wouldn't regain the weight. Some people actually exceed the weight loss that they put on. Any heart benefits that we saw before revert to pre-use. So there's no actual, it's not changing anything. It's not making anything better. It's a temporary change. More concerning ones, there was a study looking at 1 year cost after starting GLP-1 jumped 59% to 90. It's like it was a pretty huge cost. Now the drugs themselves are expensive, but this is suggesting that for some reason people using these drugs they're costing more to the medical system. What shouldn't the use of these drugs be dropping? Like, they're wonderful. Like, all diabetes goes away and obesity related. Those people should be getting less medical expenses. It turns out they're having more medical expenses. We still have yet to tease out some of that data, but it's not a good sign in the long run. My biggest concern is the muscle loss that occurs with Ozempic, especially when you combine it with not eating enough protein. That's going to be a devastating effect, and it explains why some people end up regaining the weight, because you've actually made the situation worse. Nothing will protect and sustain weight loss better than muscle mass. And if you're not adding it on, that's a dire consequence of this class of drugs. The real problem is that it's not in any way, shape, or form addressing the underlying psychological factors that underpin the decision for poor lifestyle changes. There's a huge psychological component. You look at people who childhood abuse and obesity later in life, those connections are strong. And this drug doesn't do anything to address that. And so it would make sense that after you stop, like, everything comes back. All you're doing is, probably we're going to have worse outcomes in the long run, no different than gastric bypass surgery or some of those other more aggressive approaches. So, in summary, here's some of the tips. Like, if you really just absolutely, somebody's got a gun to your head, you're like, hey, you need to take Wegovy, semaglutide, what do we do? So, first of all, the prescribing doctor, ask them if they know the background of where this drug came from. If not, they are not truly going to understand the side effects, and that's a problem. A lot of doctors prescribe drugs that they don't really understand, like acid blocking drugs. If they can't follow the pathways about everything that's going to be affected, it creates a problem because they don't understand the downsides of that drug. Need to combine this with muscle building. If the prescribing physician is not talking about this, then again, it might not be the best place to be getting this prescription, but it is an absolute must to build muscle mass. And finally, we need to address, or second to last, we need to address the psychological aspects, whether that's stress and meditation, deep breathing, biofeedback, prayer, counseling, anything like that, and get to the root of those problems that are causing us to make bad decisions. Like, diabetics know they shouldn't eat donuts for breakfast, but they still do. Why? Addressing that factor is critical. And finally, have a plan for when to stop. I have a recent patient who's he just turned 75. At 74, his doctor put him on this class of drugs. And a year later, he's lost weight, but he feels it's almost been entirely muscle. There's never been a conversation about when to pull him off of those drugs. Like, that's going to be a problem, and we had to discuss, like, he's now a year behind losing that muscle mass, and at 75, adding that muscle mass back on is going to be tough. If his doctor had talked about him that in the first place, and this is the plan, this is when we're gonna stop, and this is what I need you to do in the meantime, we'd have different outcomes. Instead, people are looking at this as the easy answer. It's not. It's just one more tool in the box that has to include diet and exercise. As always, I'm not really referring to any studies in this one, but feel free to make sure you like this video, subscribe to the channel, and I think that's about it.